Hello, welcome to my channel. My name is Mr. Today we discuss diabetes. So, in this discussion, we look at the definition, we look at the pathophysiology, we look at some investigations, how you diagnose as diabetes mellitus. We also look at some other types of diabetes, yes, the subtypes. Also look at those, and then the management. We'll make another video for it. So, diabetes mellitus is a syndrome of chronic hyperglycemia. So, this hyperglycemia is due to insulin deficiency or resistance, and in some cases, both. So, you have patients that are unable to produce the insulin that the body requires, and other patients, their body or cells are not able to respond properly to this insulin. So for them, they're able to produce the insulin, but they have poor response to this insulin. And then you have other patients that have both. They are producing less or not producing, and the insulin that is available in their system, the cells are poorly responding to this insulin. So there's insulin deficiency and resistance, or both. So this is basically where diabetes starts from. When someone has got these complications or this problem with their insulin production. So since we have seen that the problem is with the insulin and how the body is reacting to this insulin. And then we have also seen in the definition that there is chronic hyperglycemia. So now let's look at how this hyperglycemia comes about in these patients who either have a deficiency in insulin or a resistance in this insulin. So let's look at this diagram here, this flow chart here. So we can see that the first part here, the first one, we are seeing that there's decrease in insulin. So if there's decrease in insulin, what's going to happen in the carbohydrate metabolism of this patient? So since there's decrease in insulin, or there's poor response to this insulin, then there will be low glucose utilization. So the patient is not able to utilize the glucose properly. Because of this poor utilization, the body will think that the patient or the person has not taken enough carbohydrates. So it wants to supplement in the carbohydrates. So it will trigger other systems or mechanism in order to supply this glucose into the bloodstream. Yes, glycogenolysis will be initiated. So this will break down the stored carbohydrates that this patient has in the liver so that it increases the blood sugar. But remember, this patient already has the sugar. So this patient has eaten, but because there's this poor utilization of the insulin, whether it's low or there's poor sensitivity to the insulin, the patient, the body will assume that the patient has not eaten. So the bloodstream has no sugar. So it will start pumping in more sugar into the system. So now we're slowly seeing how the hyperglycemia comes in. So because of this gluconeolysis, more sugar is being deposited back into the bloodstream, this stored energy or this stored sugar. As a result, you're going to have hyperglycemia. So when you test this patient, their random blood sugars, they'll be high. So this is one of the mechanisms where the sugar is coming from. So because of this hyperglycemia, you're going to have glucose in urine. So the patient will start urinating glucose. So the kidneys want to filter out the glucose because it has detected that the blood glucose levels have increased. So other glucose molecules start seeping into the urine. So the patient will have glucosuria, and then it will cause osmotic diuretic. So because of the glucose, it will attract more water molecules into the urine. So the patient will start having frequent urination. So this is where the polyuria in the signs and symptoms comes about. We see it when we discuss the signs and symptoms. And then this, because they're urinating a lot, meaning they are also excreting some electrolytes, so it will cause electrolyte imbalance. And then this will also cause the polydipsia. And again, remember that the whole system thinks, the body thinks that there isn't enough energy. So these patients also start complaining of hunger, thirst. So everything starts from this system here, where everything starts going south because of insulin. So the problem with diabetes is insulin. So we have looked at how the body utilizes carbohydrates. So we continue. So another source of carbohydrates, or another source of energy or sugar, is protein. So because the body thinks that the patient or the person is not having enough uh, energy or sugar, because the body is poorly responding to insulin, or there's deficiency in insulin, it's also going to trigger this other pathway. So as we can see here, low insulin. So because of this low insulin, it will activate the protein catabolism. We'll start breaking down the proteins. And then to also trigger gluconeogenesis, we'll now use the amino acids from the proteins to make glucose. As a result, the patient will have hyperglycemia. So now, first, let's say we are checking these systems in the morning. The patient has eaten breakfast. So already the patient has introduced carbohydrates. But because of the problem with the insulin, the body does not know that the patient hasn't taken enough insulin, enough food. It produces more carbohydrates, more energy, more sugar from the liver. So now in the bloodstream, the sugar levels are steadily increasing. So now we have three sources. One that the patient has eaten, others from the liver, and now from the proteins. So now already the patient's glucose levels are steadily increasing. And remember, the job of insulin is to take some of this sugar into the cells and into the liver so that we maintain the normal range. But in this case, this system is not functioning properly, so it will start increasing the blood sugar. So because of this, you see that the patient will also complain of lost weight and fatigue. So another system that will be triggered is the fat metabolism. So again, the body still thinks there isn't enough sugar in the bloodstream. But remember, the patient has eaten sugar from the liver, even sugar from proteins. But again, the body still thinks there isn't enough. So it will also trigger this fat metabolism. So the lipolysis will start. It will increase in order to supply more energy to the body. So fatty acids and ketones will also be produced in order to be used to produce energy or to increase the presumed low glucose levels in the blood. So in short, the body is thinking or operating under low glucose levels. Meanwhile, there is enough. So this will trigger acidosis and lot waste. So this is also how a patient will tip into diabetic ketoacidosis. But that's a different topic that also needs another video. I'll make another video for diabetic ketoacidosis. So these are pathways that increase the blood sugars in these patients. So let's look at type 1 diabetes. So what is type 1 diabetes? So type 1 diabetes, it accounts for 10% of the cases. It usually occurs in childhood or early adulthood, age less than 30 years. So what's the main problem in this type 1 diabetes? This is due to beta cell destruction. So the cells that produce insulin are the ones that are affected in this type 1. So how does these beta cells in the pancreas find themselves damaged? So this is due to autoimmune destruction. So the body's defense system attacks these cells. Hence, the person quickly loses enough cells to produce enough insulin. As a result, they have a deficiency. So the causes will be genetic predisposition. So the patient is just genetically predisposed to this autoimmune of their cells. And then infections. So there are some instances where a patient has an infection or a viral infection, in this case, where the immune system mounts an immune response against this virus, but in the process creates antibodies against components or proteins of the pancreas, which is later attacked. So the common virus that is seen is Coxsackie virus, and then sometimes just idiopathic. So the clinical features of type 2, usually it occurs in childhood. Peak onset is between 11 to 13 years, or in young adults less than 30 years. And then patients are usually slim. Onset tends to be more sudden. So because this is an attack on these cells, so most of these cells will just almost die at the same time. So the patient will just tip into diabetic ketoacidosis as one of the presentations. So the patient will just come with this complication because the cells have died almost at the same time. So it's not progressive. It usually happens almost in a short period of time. So we move on to type 2 diabetes. So type 2 diabetes. So this one is common in people that are over 40 years and mostly in patients that are obese. So people that are overweight. So in these patients, the problem is the resistance to this insulin. So the production is intact. So the body is producing enough insulin, but it's failing to respond to this insulin. So imagine it like this. Insulin is like a key that opens a door for sugars to enter the cells. But in these patients, the key is there, but it's open in fewer doors. So that's the problem with these patients. So for them, it's resistance. So in these patients, they may progress from type 2 to type 1. The point where now they need the insulin. So but these ones can be treated with oral medications. But the type 1 patients, because they are lacking the key, so you need to put in the key. So the type 1 will require insulin for their management. So the pathophysiology of these guys, remember we have said that it's common in obese patients. So what happens is that there's an increased production of non-acidified fatty acids, leads to resistance of peripheral organs to insulin. So because of these fatty acids that the body has, because the patient is obese, that mainly causes this resistance. So in short, you have the key, but the key was jammed, so you're not able to open because of these fats. They are blocking the key wall. But again, it can be due to genetics, it can be due to environmental factors like diet. People that are physically inactive, they spend most of their time or day seated, so they are inactive. So because of this, they accumulate a lot of fats. Remember, when you have a lot of carbohydrates or you have increased sugar levels, the body will channel some of those sugars into fat production for storage. So as a result, if you're not active, the energy that you have, some of it will be stored as fats. And if you're not active, you may become obese, and as a result, you may have insulin resistance. So the clinical features of these patients that are obese, that are in type 2 diabetes, they are obese with a BMI of more than 25 kgs per meter squared. They have a first degree relative who has diabetes, history of gestational diabetes in women. Then they also may have hypertension, hyperlipidemia. Remember, hyperlipidemia are very lipids in bloodstream. So as a result, they will block the key wall and the key will fail to work. That's where the resistance over insulin comes about. So you picture it in that way. And then so now let's look at some general signs and symptoms of patients that are diabetic. So these symptoms will overlap between type 1 and type 2. Of course, some other patients like type 1 will present mostly with the DKA, and the type 2 will present with the HHS. I'll make a separate video about these two complications. So the main symptoms will be so the patient will tell you that they have frequent urination. So even as you're taking history in these patients, the first thing that they'll complain, they'll say they have frequent urination. They are usually thirsty, and they have excessive hunger. So these patients will tell you that they're eating a lot. Then they also tell you that they are thirsty, they are drinking a lot of water, and they're urinating a lot. So you're going to have polyuria, polydipsia, polyphagia. So during one round, they can ask you, Doc, why does the patient present with these signs and symptoms that you have explained or you have said? So you say, I know the patient has polyuria because of osmotic diuretic, because of hyperglycemia. So the sugar is attracting more water in the urine. So as a result, the patient will be peeing a lot. So there will be frequent urination in these patients. Then they'll ask you, why is this patient having excessive taste or drink a lot of water. It's because of the same polyuria. So the body is trying to replace the lost water. And also the thirst is due to increased blood osmolarity. Polyphagia again is because the body thinks you haven't been eating. So it wants you to eat so the idea of the body is it doesn't like utilizing the stored energy, because the stored energy is used for emergencies. So it will quickly trigger you to eat so that it doesn't touch the stored energy, because it's reserved for emergencies. This is one reason why it's very difficult to lose weight, because the body automatically wants to prevent the use of the stored energy, the stored fats. Doesn't want to play with it unless in situations where you completely need it. So as a result, it will make you want to eat more. So this is where the polyphagia is coming from. And then you have other things like loss of weight. Remember, loss of weight is when they ask you why is the patient losing weight, it's because the patient is burning fats. That's using to maintain the blood sugars. For it, it's thinking that it's maintaining, but in actual sense, it's increasing the sugar levels in the bloodstream. Remember those flowcharts that we had? Others will present with visual problems. So some patients will tell you, I am seeing cloudy vision. So that may also indicate that these patients are likely diabetic. So this visual blurring is due to swelling of the lens in the eye. Then they also have oral and genital thrush. So remember the body has got a range where the sugar levels should be. So this range is enough for bacteria. In short, is enough for the normal flora to survive. So the normal flora will utilize these sugars. When other pathogens come close to this area where these bacteria are, they'll find that all the food, all the energy has been utilized by the normal flora. So there will be competition. As a result, these bacteria that are coming from the outside will starve and die. But now in these patients that are diabetic, remember the sugar levels are high, they are not being controlled. So there's excess supply of food. So when these other bacteria or these other infections or pathogens come, they'll find enough food, because the normal flora, they have eaten their share already. Now there's extra. So they'll start feeding on this sugar. So as a result, people will present with oral or genital thrush because there's enough supply of food. Some will present with muscle cramp. Muscle cramp is either because of the acidic environment that the body is getting into, because it's using proteins, using fats, so it's producing other metabolites that are causing the pH to decrease. Then others will be lethargic, so they'll be tired, they'll be fatigued. And others will have peripheral neuropathy. So you find a patient that tells you that they feel like there's tiny pins that are pricking their feet. They feel numb. Some patients will tell you that if I step on something that's sharp, it's taking me longer to respond to that pain. So from there, you're seeing that there's peripheral neuropathy. damage to the neurons has started, because high sugar levels are toxic to neurons. This is why the body maintains it at a certain range. So ideally, everything in the body has a range. Anything below or high becomes dangerous to the body. Of course, you will have some retinopathy and leg ulcers or sores. So in this one, the problem is one, there's healing and supply of blood. So you find a person who injures themselves, or for example, they are wearing tight shoes. So because of that tight shoes, there's a small area that's been squeezed, and as a result, a small sore starts developing there. And because of these high sugars, there's poor healing. So because of this poor healing, the sore continue growing. And again, because of this sugar, it damages the blood vessels, the peripheral blood vessels. As a result, supply to that area of oxygen and immune cells is low. So healing delays, and fighting any infections in that area is low and reduced. As a result, it kills the area there, and the infection or the sore starts increasing in size. A boy here is just showing some differences between type 1 and type 2. What you expect to find in these patients, their age, weight, symptoms, risk factors, genes, pathogenesis, whether they have ketones in urine or not. So if you see in ketones, you're finding some in type 1, but in type 2 it's not there, because the system that produces ketones is not fully utilized in type 2, because there's a bit of insulin being produced, and so on. And then you can see pathogenesis in type 1 is immune mediated, so there's autoimmune, but in type 2 it's not there. So you can use this table. Okay, so there's also gestational diabetes. So I'll discuss this one more in OBG. Yeah, that's where I'll talk more about gestational diabetes. But this one develops during pregnancy and is detected at 24 to 28 weeks of gestation. So this one is also associated with high risk of cesarean section and the neonatal complications. So I did a video in pediatrics of microsomia, and gestational diabetes was a risk factor. So because there's a lot of sugar, remember diabetes, you have high sugar levels. So there's high supply of sugar levels to the fetus. As a result, the fetus has enough food to grow big. This is why there's an increased risk of cesarean delivery, because these mothers tend to have big babies weighing more than 4 kgs. Then we have secondary diabetes. So this one is a diabetes that's a result from another medical condition or due to the treatment of a medical condition that causes abnormal blood glucose levels. So in this one, there are a lot of causes that would cause secondary diabetes. It can be due to drugs or chemicals. It can be due to endocrine pathologies. It can be due to immunosuppressive agents. So this table here has got some other causes of diabetes. So sometimes when I'm managing patients, you may have a patient that's diabetic and you keep on managing the diabetes, forgetting to check other causes that once fixed, the patient would recover from this diabetes. So this is why taking a good history and examining the patient is good. So you may have a patient that's diabetic, but you missed that the patient has Cushing syndrome, because we are seeing here on this table that it can be one of the causes of diabetes, or maybe the patient has got a neoplasm somewhere. So it's important that you also know some of these causes of diabetes. So the other new classifications of diabetes. So these are subgroups. There are 5 subgroups, and these subgroups they explain more on the type 1 and type 2. So type 1 is said to have autoimmune, and type 2 is resistance. So out of these 5 subgroups, there are some groups that are due to this autoimmune, others are due to resistance. Okay, so the first group in this subgroup is severe autoimmune diabetes. The second one is severe insulin deficient diabetes. Third one is severe insulin resistance diabetes. Then you have got a mild obesity related diabetes. Then you have got a middle age related diabetes. So there's more information that I will explain in another video specifically on these subgroups. But in this video, I'm just introducing these subgroups and other types of diabetes. Another type of diabetes is the LAD, Latent Autoimmune Diabetes in adults. So this one is sometimes called type 1.5. It's a type of diabetes that has characteristics of both type 1 and type 2 diabetes. So you have a patient that's obese, family history, then the patient also has the autoimmune against the beta cells. So the patient has got both. So this one is overlapping between type 1 and type 2. So it happens because your body makes antibodies that attack insulin producing cells in your pancreas. Symptoms begin in childhood and worsen gradually, which often leads to a type 2 diagnosis by mistake and eventually insulin dependence. So you have a patient that is presenting with both or risk factors of type 1 and type 2. So you check they have antibodies that are attacking the insulin and some other risk factors of type 2. But because it's usually in adults and worsening gradually, as a result, it may be mistaken for type 2 diabetes. So you find a patient that you are doing a random blood sugar, then you find the patient sugar levels are high. So because the patient's blood sugar is high, and then the patient maybe is over 30 years, maybe mildly obese, So you may think, maybe this patient, this is type 2 diabetes. But in the actual sense, it's latent autoimmune diabetes in adults. So eventually, you start them on oral medications, but the patient is not responding. You think maybe it's just poor compliant, but the patient indicates that the patient is compliant to medication. You try to admit the patient so that you can administer these medications yourself. Still, the blood sugars are not improving. But the moment you start the patient on insulin, the patient starts improving. So it may be because you had misdiagnosed this patient to be a type 2 instead of a LAD patient. Or you have a patient that was responding well to medication, oral medication, and then with time, the patient just stops responding. You try to change the medication, still the patient is not responding to these medications until you start them on the insulin. So this would be one of the reasons. So there's another type called MODY, which is Maturity-Onset Diabetes of the Young. So this one is a bit rare. So it's genetic form of diabetes caused by a mutation in a single gene affecting the pancreatic beta cell function. So this one is like it's like type 1, but in these guys there's no autoimmune, so the immune system is not attacking these cells. The problem is the cells themselves that are failing to produce the insulin. So there's a problem with their genetic makeup. So this is what this maturity onset diabetes of the young is. So unlike typical type 1 diabetes and type 2 diabetes, MODY is monogenic and inherited in autosomal dominant pattern, meaning a child has a 50 chance of inheriting the condition if one parent has the mutated gene. So this one is genetic mutation. So the beta cells have not been designed genetically to produce enough insulin. As a result, the patient may have diabetes. So there's poor functioning of the cells. So the cells are there, but they're poorly performing. There are no antibodies or there are no immune systems attacking these cells. So these are other forms of diabetes. So we have discussed 5 subtypes. We have said the severe autoimmune diabetes, the severe immune deficiency, severe immune resistance diabetes, mild obesity related, mild age related diabetes. And we have also discussed LAD, latent autoimmune diabetes in adults, and MODY, which is maturity onset diabetes of the young. I'll make specific videos on this because they're also long topics that we cannot fully discuss in this video. So let's move on to a few phenomena that we experience or a few effects that we may have in these patients with diabetes. So the first one is the dawn phenomenon or effect. This is defined as an abnormal early morning between 3 a.m. to 7 a.m. increase in blood sugar levels in a patient with diabetes mellitus. So this is due to during sleep there is a surge in the secretion of counter-regulatory hormones like cortisol, glucagon, growth hormone, catecholamines. So this will cause a release of glucose from the liver and increase insulin resistance, leading to hyperglycemia. It is often related to insufficient insulin dosage at night and may require increasing the night dose of insulin. The patient should be advised to avoid taking carbohydrates at bedtime. So you have an instance where the patient does their glucose test in the morning and they find that the sugar levels are always high. You ask them, are you taking your medication? They tell you, no, I take this medication the way instructed. This would be one of the reasons why the patient is having an increase in their sugar levels in the morning because of this effect. So the body is just trying to have enough supply of glucose, but these patients have poor control of glucose. So as a result, they end up with hyperglycemia, waking up in the morning with high glucose levels. So for us, or for normal patients, for normal people without diabetes, they have this phenomenon, but because they have good sugar controls, even if there's increase in glucose levels, their body is able to reduce this by the time they wake up to their normal ranges. And then we have another one, MODY effect or MODY phenomenon. Is defined as pre-breakfast hyperglycemia, which follows nocturnal hypoglycemia, which often goes unrecognized. That leads to increased release of counter-regulatory hormones that produce high blood sugar, high blood glucose. In this case, the previous night's insulin dose is often higher than required. This commonly seen in children. Treatment by in this MODY effect, the blood sugars in the morning are high, but around 3 a.m. the blood sugars are low. So this is how you differentiate between a dawn and MODY effect, because in both, remember, in both there is hyperglycemia in the morning, but in MODY phenomenon, 3 a.m. blood sugar is low. So when you test this patient's blood sugars in the morning at 7 a.m., you find that all their blood sugars are high. But when you test the blood sugars of around 03, you find that in MODY effect, the blood sugar levels are low. So that's the difference between these two phenomenon. Another thing that you can find in these patients is brittle diabetes. So this one is where you have a patient that tells you, or you are sure that this patient is following all the instructions you gave them, but for some reasons they are failing to control their sugar levels. So for some reasons that you don't know, find their sugar levels are high, the other day they are low, they are normal. So for no apparent reason, they have got swings in the blood sugars. It's high, it's low, it's normal. So it may be, maybe they have some other problems that you have not dealt with, or the patient is just poor responding to the medication that you have given them. So you may want to change the medication. So we have discussed a lot about diabetes, the subtypes, the types, and other forms of diabetes. So now we want to see how we can diagnose this diabetes in these patients. So you have a patient that you're suspecting as diabetes, they are overweight, they have a family history, they have got those signs and symptoms, they tell you that they are complaining of excessive urinating, hunger, low waist. So you want to check if they have hyperglycemia, so that you can now know that this is diabetes. So the first thing that you can do a fasting blood sugar. If it's more than 7 millimoles per liter, that would indicate that the patient is diabetic. So you may want to make this person not eat for at least 8 hours. So this one can be done in the morning. So you know that the patient had their supper around 20. So you know that by tomorrow morning they will not eat anything. So you expect their blood sugars to not be more than 7 millimoles. Or you can do a random blood sugar. So you expect this one to be more than 11.1 millimoles. So this random blood sugar is regardless of whether they had a meal or they didn't eat anything, meaning that patient is diabetic. Then you can do an oral glucose tolerance test. So in this one, you give a patient 75 grams of anhydrous of glucose dissolved in water. During an oral glucose test, the patient is asked to fast the night before at least 8 hours. The next morning, the blood glucose is monitored and glucose is administered, and the blood sugar level is checked and recorded after 30 minutes and after 2 hours. So in this case, you let the patient fast. So you can do this in the morning, because you know that the patient of us will not eat anything at night. Then you check their blood sugars. Then you give them some food. Then you check again their blood sugars. If they are more than 11.1 millimoles, then you'd say they are diabetic. Another test that you can do is to check the HB1C. So you check the HbA1c. If it's more than 6.5%, then you'd say these patients are diabetic. So this one simply reflects the amount of glucose attached to the red blood cells between 90 to 120 days. So these are the tests that you do to confirm that the patient has diabetes, together with the signs and symptoms and the history. So other supportive investigations that you do urinalysis. So in urinalysis, you're checking for glucose. Remember, if there's high glucose, they'll put some other glucose in urine, so you can do a urinalysis. So they will go urea. Then you can check for ketones in urine. You can check for proteins in urine. You can also check for infections. Remember, they have high sugar levels, so they have a lot of food. The immune system is also low, so it's easy for infections to grow quickly out of control. So you may want to check for a UTI in this urinalysis. And you may also want to check for other abnormalities like blood in urine, because sometimes patients may present with yes, diabetes, but also hypertension. So you want to check if the kidneys are not damaged. And then another test that you do is a full blood count. You're screening for infections. Remember, high sugar levels lowers the immune systems. So you also want to check for infections. You also want to check for anemia. You also want to check your platelets and the clotting risk. So in short, you're doing this full blood count just to have a baseline so that you know the general health of the patient. Then you can also check the urea and nitrate, urea and the electrolytes to check for kidney function. So you want to check how their kidneys are functioning. Remember, sugar affects the kidneys because it's even one of the complications. So you want to check the kidney function, detect if they have any electrolyte imbalances, and it can also use to diagnose and manage DKA and HHS. Then you also want to check their liver. So you do a liver biochemistry to check for liver function. So you're looking for, you're detecting for fatty liver disease, non-alcoholic fatty liver disease. You're checking for any damages or inflammation. Then you can also use it to monitor drug effects and function. Then you can also check their lipid profile. So in this lipid profile, you're looking at if they are at high risk of heart diseases, which can also help you manage this patient. You're also checking for if there's any dyslipidemia. Maybe this patient is diabetic because of this dyslipidemia. Remember, we said that fatty acids or fats can affect the response of cells to insulin. This is why obese patients tend to have type 2 diabetes. So this is why you're checking this lipid profile. So you want to just check their fats in general. And also try to assess risk of heart diseases. So this is why you're doing other investigations. These are the investigations that we're talking about. So for complications, I'll just list them. So for complications, we have got some acute complications. So this can be diabetic ketoacidosis. You can also have hyperosmolar, hyperglycemic, non-ketotic syndrome or coma. Then you can also have hypoglycemia. So this hypoglycemia is due to medications. Due to medication where the patient maybe they overdose the insulin. So as a result, they go into hypoglycemia. So other chronic complications, you can have retinopathy, you can have neuropathy, you can have diabetic foot or ulcer. Then you can also have some, you can also have nephropathy. So complication with the kidneys. So and other complications like strokes can also lead to amputation, especially if the diabetic foot is poorly controlled or managed. So we have discussed a lot of things, but this is not the end of this topic. I'll make another video on management and on all those other things that I've talked about, like the LAD, the 5 subgroups, and also on the MODY. So I'll make separate videos for each, and thank you.